My name is Sandy Moline, and I am a part of Team 4 with Angelo, Chase, Nicholas, and Wayne. In our presentation, we will be discussing our abstract problem statement and our annotated bibliography for our thesis. My problem statement is how can U.S. Food and Drug Administration, FDA, help reduce health complications from the COVID-19 vaccination in Black women's health? The reason why I chose this as my problem statement is because I have encountered many women who have experienced complications after receiving the COVID-19 vaccination. They have experienced menstrual complications, autoimmune diseases, cardiac diseases, and respiratory diseases. The reason why I gained interest in this problem statement is because several women have shared their experience with me, and I personally believe that additional research and testing should have been done with the COVID-19 vaccination before it was approved by the FDA. There are three main COVID-19 vaccines, two which were approved by the FDA, which were Pfizer and Moderna, and then we have Johnson and Johnson. The FDA approved the first COVID-19 vaccine, which was Pfizer, on August 23rd of 2021, after the first outbreak of COVID-19 in China in December of 2019. Personally, I feel that there was not enough research and development and testing done before the first COVID-19 vaccine was approved, because typically a vaccination takes about 10 years minimum before it is approved. And the COVID-19 vaccine, Pfizer, took about 2 years before it was approved by the FDA. Typically, Black women receives inadequate care, and I believe that for in order for the Black community to receive or less likely be hospitalized for COVID-19, more testing should be done with the vaccination. Because of this, Black people have become hesitant in taking or receiving the COVID-19 vaccination because they're afraid of the future or the outcomes of receiving health complications. According to the CDC, about 13.7 million COVID-19 vaccine doses were administered in the US, and 7,000 people reported side effects, about 79% being women, and about three times, Black women were 3 times more likely to die from the COVID-19 complications than others. My four main sources will be the CDC COVID tracker database, which provides the number of cases and deaths before and after being vaccinated. And my second source it talks about the effects of the COVID-19 vaccine amongst women compared to men. My third source is predominantly or specifically focuses on the Black and Latina community. And my last source will be raw data from an OBGYN. And now I'm going to pass the presentation to Nicholas.
Thank you, Sandy. That's a very interesting topic, and I can't wait to read your thesis in November. My thesis is focused on diabetes and insulin. Recently, Congress passed the Affordable Care Act, which part of that act is, but it put it set a copay for Medicare beneficiaries of a $35 copay. So for insulin, so they don't pay more than $35 for insulin, and so they did leave out non-Medicare patients and also the non-insured. So my problem statement is how can Congress make insulin more affordable to non-Medicare patients? If you don't know what diabetes is, it is high blood sugar in your body. There is two types. The type 1 is when your body's not producing enough insulin, and type 2 is when your body's unable to properly use the insulin in your body. Diabetes is the eighth leading cause of death in the United States. Every year, 1.4 million people of Americans are diagnosed with diabetes. In 2019, 37.3 million people, or 11.3% of the US population, had diabetes. And so if you're type 1 or type 2, you'll use you're deep, a lot of you, a lot of uh, uh, type 1 or type 2 diabetes, a lot of individuals with type 1 or type 2 diabetes are insulin dependent, and so they either will receive a rapid acting, or short acting insulin. Either they can use one of them or two of them depending on their condition. And there has also been an increase of 4.5% between 2006 and 2019 in emergency department hyperglycemic crises for adults over 18 years of age. It is increasing, and more people are being, you could say, dependent on insulin, and prices are getting higher. If we go to the next slide. According to the CDC, diabetes is the most expensive condition in the United States, with $237 billion spent each year on direct medical costs. The total economic cost of diabetes rose uh, more than 60% from 2007 to 2017. And if diabetes is left untreated, or you're non-adherent to treatment, this can lead to cancer, Alzheimer's disease, dementia, high blood pressure, cardiovascular disease, and other health complications. The few sources I used, if we go to the next slide, here we have the United States Diabetes Surveillance System. This will provide me with the estimates and trends of diabetes prevalence, incidences, and risk factors. There is a study done by McCann Marks and other authors that shows a correlation between high out of pocket costs and non-adherence. So the higher the cost is, the more likely that patient will be non-adherent to treatment. And like I stated before, this can lead to other health complications. There is an article by the American Diabetes Association. This gives the reader a detailed description of all stakeholders involved: manufacturers, pharmacy benefit managers, pharmacies, and their individual impact in the price of insulin. And for my last um, uh, resource, if we go to the next slide, um, there is this article by Rak Kumar. He talks about the three companies that own 99% of the world's insulin. It is a monopoly, and the patent evergreening. What this is when a company extends the lifetime of their patent, that is about to expire, in order to retain the revenues. So they'll make small improvements so they can extend that lifetime of the pattern. And this has been going on for quite some time, and it has had an impact in rising prices for insulin. Now, it is for Angelo to present his problem statement to you.
Thank you very much, Nico, and I look forward to reading your thesis back in December. Now, for my problem statement, I am going to be talking about how Hospital Corporation of America, also known as HCA, one of their hospitals, which is Northwest Hospital Emergency Department, can improve its throughput. Now, one of the main questions that is faced with when it comes to patients is asking, what is throughput? Well, throughput is the measure by how long the patient stays in the hospital. So from the time they arrive to the hospital to the time that they are discharged. And one of my main reasons why I am doing this thesis on this hospital is because that they were having issues regarding increasing the patient throughput because of overcrowding and delays within the emergency room. And overcrowding and delays in the emergency room can cause a lot of different mortality rates, and it can also decrease satisfaction between both employees and patients, because inefficient use of resources is also one of the results that comes from overcrowding and decrease in delays within the emergency room. Another reason from overcrowding is the ER wait time. A recent study shows that approximately the ER wait time is 24 minutes for every single hospital that have annual visits of 20,000 patients per year. When, on the other hand, there is 48 minutes for hospitals that are receiving 50 more annual visits within the year. And HCA Northwest Hospital is receiving approximately 75,000 visits per year, and their ER wait time is between 50 minutes to an hour. So this is a main issue that the hospital is being faced with. Next slide, please. So during COVID, ACA received an influx of COVID patients and non-COVID patients, unfortunately. And because of this caused a lot of delays to its discharges, admission dates, and distribution of medications. And in some rare cases, the hospital was caused to be put into ambulatory diversions, which means that the hospital was no longer able to receive any patients. So if there's an emergency, patients will have to be sent to the nearest hospital outside of HCA Northwest Hospital. And that is a big issue when it comes to their finances, because an increase or decrease in the number of admissions within the hospital by one day will net a positive or negative decrease or increase within the institution by $800,000 a year. So every single patient that walked out the hospital, that's $800,000 a year that is being subtracted from the hospital's revenue. And this is a main issue in building the hospital, because the more patients that are dissatisfied and the more patients that are walking out means that the hospital is using more revenue and more income. Now, for my annotated bibliography, I've used a few different sources. For my raw data, I am going to be collecting data from HCA Northwest Hospital itself and Broward Health Medical Center, which is one of their competitors. And I'm also utilizing the CDC and the National Center for Biotechnological Informations, which are the two main organizations that are doing surveys in regards to patient satisfactions, overcrowding, and ER solutions and problems. With that said, this has been my problem statement, and I'm going to be passing it to Mr. Chase to talk about his problem statement. Thank you.
Thanks, Angelo. I work in an emergency department, so I'm excited to see what your outcome is for your thesis. I see that on a pretty daily basis on what that impact looks like from the employee side. So for myself, I am trying to help Florida Medicaid save money. So my problem statement: how can direct primary care reduce costs for Florida Medicaid by them using or utilizing direct primary care subscription services statewide? So first, what is direct primary care? Direct primary care is a form of primary care where an individual pays their physician or their primary care directly versus paying a premium to a third party who then reimburses the primary care for any of the services rendered. This is a benefit in multiple ways, in that someone can now utilize their primary care the same way they would utilize a gym membership, where they can go when it's most convenient for them. The primary care office tends to have more availability. They have to see fewer patients to become profitable, and you're dealing with each other directly versus having to work through a third party. So why would utilizing a direct primary care practice help Florida Medicaid reduce costs? Well, the biggest reason is going to promote that patient to physician relationship. When patients and physicians have a good relationship with each other, patient is more likely to be compliant with any medications that are being prescribed, following any recommendations outside of medications that the physician is recommending, and is more likely to bring up issues to the physician as they arise versus waiting and waiting and waiting until they become big issues. It's a form of comfort, and it's also a good financial outcome for a physician's office to have this type of this practice. So a fee-for-service model is very common today, where many practitioners are paid per the services that they utilize. This tends to cause certain practitioners to focus on a defensive style of medicine. Defensive medicine is overutilizing tests and more expensive. Well, let's see. So utilizing expensive tests because of a lack of information about a specific patient. So they're going to be doing CTs, MRIs, blood work, because they don't know what the patient already has, and there's a lack of sharing. It is estimated that over $700 billion is wasted in the United States healthcare system every year. Some of the biggest costs are going to be administrative, defensive medicine, or waste of resources, and then there's fraud. There are some additional wastes. These are some of the three big ones that a lot of people tend to focus on. Direct primary care can help reduce administrative waste while increasing primary care utilization with patients. So it's a 2-for-1 essentially. Direct primary care, increasing that primary care utilization by the patients, and allowing Medicaid to pay for health issues when they're less expensive and less severe. Sandy? So approximately about $100 billion is wasted annually just on administrative costs between third-party insurances, healthcare practices, healthcare systems. Think about the number of people that have to be hired just to deal with insurance. In fact, a lot of doctors' offices, the doctor will only see patients for 15 minutes, but they may spend at least an hour trying to make sure that everything's put correctly into the patient's system so that they can get reimbursement from an insurance. So if you're focusing more on where's the money coming from versus the patient's going to have a less positive outcome, and they're not going to likely want to come back because they've only spent 10 minutes with their doctor. Underutilization of primary care, as stated previously, increases or exacerbates small healthcare issues because patients tend to hold off until it gets to the point where it's an emergent situation. They end up in an emergency room. Potentially, they have to spend multiple nights in the hospital for something that could have been prevented 2-3 weeks ago, 4 months in the past, when it was a very minor issue and may not have cost more than a couple of dollars to alleviate. Sandy? So many of the resources that I have for my thesis involve what is direct primary care and how it's going to affect Medicaid financially. This first one here is specifically about how primary care practices have been dissolving or being absorbed by larger healthcare systems. That small town, I know who my doctor is, and everybody goes see them because they're good. You would tend to be losing a lot of that. So people are less willing to go and see their primary care, which again makes small situations even worse because people put it off. Second source here is going over the differences between direct primary care and other types of concierge type care. Concierge care, thinking of, what do rich people have? Oh, they have a doctor on call, or, lawyers would be a type of, the way people think of lawyers, right? You've got them on call, they're beck and whim, maybe they've only got a couple of people that they work with. So it's reducing that potential 3,000 a month patient load to 200 patient load for a direct primary care out of a traditional care, while a concierge care may be 10 patients per doctor. The next article covers a lot of the impact of a fee-for-service system within our healthcare. And the last source I have here is data based on waste within the U.S. healthcare system. And with that, I'd like to go ahead and pass the rest off to Wayne.
Thanks, Chase. Man, yours sounds really exciting. Can't wait to see how that applies to the Medicaid program. So mine, actually, just to put it in context, is kind of dealing with the employment situation of healthcare clinicians in the current situation right now, and the rumors or the often kind of comments that we hear that we're looking towards a healthcare shortage in the upcoming future, as possibly as soon as 2025 or 2030. And by that, I mean a potential nursing shortage, a potential physician shortage, a potential therapist shortage, potential pharmacist shortage. We're looking at all of that within the next kind of 5 to 15 years. Those are rumors that have been going on. Now, although a lot of healthcare systems tend to focus more on trying to recruit new employees into the system, there doesn't seem to be as much of an emphasis on existing programs to retain the staff that we have in place. And ultimately, that was the problem that I kind of identified and I wish to explore. So, what initiatives should a healthcare system employ to try to address frontline clinician employment retention? Next slide. So the big issue kind of often comes down to employee staffing versus employee retention. So healthcare systems often at the highest level from C-suite and vision and really future kind of planning is really expansion of resources and how are they gonna be accumulating staff to kind of fill those spots. But there doesn't seem to be as much of an emphasis on employee retention. Now in the time that I've been kind of investigating this, often with respect to reasons for why employees consider leaving their current positions. Among the biggest ones are often the feelings of dissatisfaction, employee exhaustion, and really leading to the extreme of burnout. And there is an actual clinical condition of burnout that we often end up kind of hearing about, but even to the extreme of it, we can actually almost see some clinicians actually meet criteria for post-traumatic stress, given to the amount of experience that they've had just in the current kind of conditions that they've had to deal with. Often another kind of big characteristic is pay, where employees may not necessarily feel like they're making sufficient pay for really the third one, and what they're dealing with is the workload of what they're dealing with. So although there are established kind of guidelines for what should be an adequate kind of patient to clinician kind of ratio, there's, with the exception really of California, there isn't really any kind of state mandated specific regulations for that. But really, we see that in the last couple of years, the trend has been definitely more of an emphasis of trying to push what that ratio is going to be, or just the acuity of the patients, even if those ratios are being respected, the acuity of the patients that each clinician is having to deal with. And COVID really since about 2020 has just put a big magnifying glass, or really has put this all under the microscope that's just seemed to magnify and accelerate how quickly people get to the point of feeling burnout, or just that depersonalization and that emotional exhaustion and that they get with their limitations in their current position. Pay differences have definitely been just that disparities have just been that much more illuminated. As if you can remember in 2020, where we started to see a lot of travel clinicians kind of moving around, and they were getting paid 2, 3, 4 times what staff employees would be getting paid. And to try to meet just patient needs, especially when we were in the first wave with COVID, and then when we were in the COVID wave of Delta, where we were dealing with very high acuity and just the extent of the number of patients that were hospitalized. Again, that ended up magnifying that as well. So COVID ended up just kind of putting a magnifying glass on what was going on. But what we also ended up seeing was, and Sandy, if you can just go to the next slide, we ended up seeing that also really over those kind of couple of years, although normal kind of hospital turnover for employees may range about the 18 to 19%, as we could see back in 2017 and 2018, and for full-time and part-time employees only, so not all the administrators and the support staff, we can see that was running about 16 to 17%. When we got to 2021, we've seen that there's been a jump up to almost 26%. And for these full-time and part-time, really that's reflecting more clinicians. We're actually up to about 22%. And if we make that a breakdown as we go to the next slide, for nurses in particular, we're seeing that back in 2018, we were sitting around 17% for all nurses and about 15% for those full-time and part-time only kind of clinicians. And now when we get to 2020, really when we're starting to deal with COVID, we're up around 18%. And then in 2021, we dropped up to 27%. And 22%. So we're seeing significant kind of changes in what that turnover rate becomes. And just to kind of equate that with dollars, so although I'm just specifically talking about nursing here, for nurses, just based off of this study that was based off, and I'll kind of show you the reference, I'm sorry it didn't appear on the slide, by Coleri, what it showed was, so for the turnover for a nurse, for one nurse, it's estimated to be about 35 to 40,000. And if we're looking at a salary for a nurse that can range anywhere from about 45 to 75,000, that's a significant amount that we're dealing with. And that's just for one particular nurse. When you multiply that for the number of nurse vacancy positions that are there for nurses that have now left or have transitioned to another spot, that does actually start to become significant. For a physician, where an employed physician could be anywhere from 200,000 to about 350,000. If we're equating that, that might be about $100,000 just in the attempts in dealing with a physician that is now left and trying to recruit a new physician. That kind of money does start to add up. But the nice thing is, and really from the annotated bibliography, this is just a sampling of the stuff that we've kind of seen. That first one ends up giving a good kind of definition of the patterns that clinicians often end up going on with, identifying and breaking them down by psychological, environmental, and social characteristics that contribute to those stressors. The second one ended up providing a pretty good data set based off of surveys that was representing 272 hospitals from 32 states, over 580,000 employees, and over 160,000 nurses. That was during a data collection sample of that 2 years of 2020 to 2022. So really in that big period where COVID was magnifying everything that was going on. And the last one, which kind of leads into the other crux of the investigation, is not only is it identifying these factors that lead to people considering leaving, but what were some of the supporting kind of factors that led into people considering not leaving. And that would kind of deal with stable kind of caseloads, where they felt that they had some decision that was involved, or if they had confidence in their, not only in their co-workers and stability that was there, but also in their unit management and their hospital management and leadership, as well as if they felt that they had resilience or some kind of coping methods and support system in place. So that's just a sampling of what I'm kind of looking at. As you can see, our group was really targeting a real nice cross-section of elements within our whole healthcare system, from primary care to medications to vaccines, all the way through to throughput and operations within hospital departments, to the employees and healthcare clinicians themselves. So this is really looking forward to very promising kind of studies that I hope will end up influencing our target audiences. So thank you very much.